disorders. Today's presentation is on my clinical research paper, that is white matter impairment and cognitive desecration after traumatic brain injury. I thank to my co-author. She is from India, and she is my sister too. She is also a doctor. So firstly, what is white matter? White matter is found in deeper tissues of brain, that is subcortical. It contains nerve fibers, axons, which are extensions of nerve cells, that is neurons. Many of these nerve fibers that are surrounded by a type of cell called myelin. Myelin gives the white matter its color. In the most general sense, the gray matter of brain facilitates information processing and white matter facilitates information transfer. So both are critical for efficient operation of the neural networks responsible for a specific mental domain. So now, what is traumatic brain injury? TBI, also known as intracranial injury, is an injury to the brain caused by an external force. So TBI can be classified based on severity, ranging from mild traumatic brain injury, MTBI concussion, so severe traumatic brain injury. Mechanism: closed or penetrating head injury, or other features that may be occurring in a specific location or over a widespread area. So head injury is a broader category that may involve damage to other structures such as scalp, skull. So TBI can result in physical, cognitive, social, emotional, and behavioral symptoms. So outcomes can range from complete recovery to permanent disability or death. This is a small presentation which is shown by traumatic brain injury. You can see the disorders like cerebral edema, hypoxia, ischemia, cerebral metabolic impairment, cerebral vasospasm, increased intracerebral pressure, cell death, increased glutamate, complement activation, inflammation and ROS generation, excitotoxicity, BBB damage, and mitochondrial dysfunction, impairment of glucose metabolism as well. So now we're going to move to abstract. White matter disruption is an essential determinant of cognitive impairment after brain damage. However, conventional neuroimaging underestimates its volume. In comparison, diffusion tensor imaging presents a confirmed and sensitive way of figuring out impact of axonal damage. The connection among cognitive impairment after traumatic brain injury and white matter damage is probably to be complicated. So we implemented a flexible approach, tracked primarily based spatial statistics to explore whether damage to particular white matter tract is associated with particular patterns of cognitive impairment. The commonly affected domain, names of memory, executive function, and information processing speed were investigated in 28 patients within the post-acute chronic segment following traumatic brain injury, and in 26 age match controls. Evaluation of fractional anisotropy and diffusivity maps found out significant differences in white matter integrity among the groups. Patients showed massive regions of reduced fractional anisotropy as well as increased mean and axial diffusivity compared with control despite the small amount of cortical and white matter damage visible on preferred imaging. A stratified analysis primarily based at the presence or absence of ecroblitz, a marker of diffuse axonal damage, revealed diffusion tensor imaging to be more sensitive than gradient echo imaging to white matter damage. The reason of white matter abnormality anticipated cognitive function to some extent. The structure of the fornices became correlated with associated learning and memory across both patient and control groups. While the structure of frontal lobe connections showed relationships with executive function that differed in the groups, those results highlight the complexity of relationship between white matter structure and cognition. Although widespread and sometimes chronic abnormalities of white matter identifiable following traumatic brain injury, impact of these changes in cognitive function that is likely to depend on damage to key pathway that link node in distributed brain network assisting high-level cognitive functions. So traumatic brain damage frequently results in specifically to cognitive impairments. Maximum survivors are younger and have normal life expectancy. Hence the burden on public health and social care is significant. Cognitive domains like memory, executive function, and processing speed are commonly affected. Despite much work, the underlying pathophysiology of this chronic impairment remains poorly understood. Now, even though focal brain injury often occurs as a result of traumatic brain damage, in a lot of cases, the location and extent of this injury does not fully give an explanation for patient's cognitive issue. That is likely to be because damage to brain connectivity is a critical factor in development of cognitive impairment after traumatic brain injury. Functions typically impaired, memory and executive function depend on coherent activity of widely dispersed brain networks. Nodes in this network are connected by long white matter tracts that may be damaged in traumatic brain damage as a result of diffuse axonal injury. The pathology of diffuse axonal injury has been investigated in some element. However, until recently, it has been difficult to study the location and extent of this damage or its functional outcomes in vivo. Conventional CT and standard MRI underestimate the extent of white matter damage after traumatic brain injury. Standard MRI of traumatic brain injury includes the use of gradient echo imaging that allows the identification of microbleed. Those are surrogate markers of diffuse axonal injury, and the presence is related to persistent cognitive impairment. However, pathological research often show more extensive axonal damage, which is unlikely to be completely contemplated in focal microbleed signal abnormalities. Recently, it has become the tensor model, that is DTI information, are used to estimate the amount water diffusion in a number of directions at each factor, that is voxel in the image. From this matrix, such as fractional anisotropy can be derived to quantify the degree of white matter disruption, greater anisotropy, indicated by higher fractional anisotropy value, that is believed to reflect more coherent tissue structure, while its increased diffusivity suggests tissue damage. Now, experimental models of axonal damage and demyelination have implicated axial and radial diffusivities as potential biomarkers of axonal and myelin loss, respectively. So now, modifications in fractional anisotropy persist after traumatic brain injury and predict functional outcome over and above patient's initial clinical state or focal lesion load. So previous work in patient with traumatic brain damage has generally focused on restrained number of brain location described as a region of interest. So this approach is a sensitive way of identifying white matter damage, but as it is restricted to assessment of the priorly described regions, only a small quantify of the total matter is normally investigated, that is complicated for some of regions. So traumatic brain injury produces a complex pattern of diffuse axonal injury as well as variable locations across individual, so it is difficult to determine priori where to look for white matter disruption. The research of a small number of regions is likely to result in a failure to identify significant white matter damage elsewhere in the brain, as the cognitive features commonly affected by traumatic brain injury that depends on distributed network function, such as approach limit analysis of structural causes of cognitive impairment. These tissues are compounded by a limited knowledge of how tract structure relate to cognitive function in the normal brain, making it essential to assess white matter structure after traumatic brain injury with its comprehensive spatial coverage as viable. So tract-based spatium has a white matter structure throughout the whole brain. The voxel base is provided critical insights into long-term consequences for cognition of brain damage. TBSS allow complicated patterns of white matter disruption to be identified and the relationship with cognitive function to be studied in a data post way. So statistical calculations are accomplished at each point within an individual white matter skeleton, which has been registered to standard space using a stage process involving non-linear wrapping and subsequent alignment of individual white matter tracts throughout subject. This permits a comprehensive analysis of tract structure to be performed in a way that is robust to effect of brain damage, such as brain atrophy. TBSS has been used to show a relationship between white matter structure and cognitive feature in different neurological conditions. Here we used TBSS for the first time to study the relationship between distributed white matter damage and cognitive impairment following traumatic brain injury. First, we investigated whether there were differences in white matter structure in a set of post-acute and chronic patients with traumatic brain injury and an age-matched control group. We then investigated whether the pattern of white matter structure predicts cognitive function in three domains, that is commonly affected by traumatic brain injury, that is memory, executive function, and information processing speed. Our prediction was that increased white matter disruption following traumatic brain injury will be associated with greater cognitive impairment, but that distinct type of impairment are associated with particular patterns of white matter abnormalities. So memory function is highly based upon hippocampal medial cephalic interactions mediated through phonesis, learning, and memory, that is impaired chronic traumatic brain injury, and white matter structure within the hippocampal formation that has previously been shown to relate to associated memory performance. We therefore predicted that white matter structure of the hippocampal connections will correlate with memory performance. Executive functions are widely thought to depend on interaction between the frontal lobes and more posterior brain regions and a relationship between executive dysfunction and age-related decline in white matter integrity within tracts connecting frontal region that has previously been demonstrated. Therefore, so we predicted that breakdown of these frontal connections following traumatic brain damage will similarly correlate with executive impairment. Ultimately, white matter organization has been shown to predict processing speed on a range of simple tasks in healthy people consequently. So we expect white matter structure as measured by DTI to correlate with information processing speed. So method: 28 patients with traumatic brain injury in the post-acute chronic phase, 21 adult males, mean age SD 38.9, 12.2 years, an age match group of 26 healthy controls, 12 adult males, 35.4, 11.1 years were recruited. This is a clinical trial. All patients have been recruited at least months post-damage, average 25 months. Injury was secondary to assaults, 36%, road traffic accident, 32%, that falls under 25%, and sports activity related injury, 7% patients have been referred to the local traumatic brain injury service due to presence of functional impairment following their head injury. There were 20 moderate or severe and 8 slight probable cases based on Mayo classification system for traumatic brain injury. Severity relating to the duration and loss of consciousness, length of post-traumatic amnesia, lowest recorded Glasgow Coma scale in the first 24 hours, and a CT or MRI result. Exclusion criteria were as follows: neurosurgery, except for invasive intracranial pressure, monitoring ends to 1, history of psychiatric or neurological illness prior to the head injury, a history of previous traumatic brain injury, anti-epileptic medication, current or previous drug or alcohol abuse, or contact addiction to MRI. All participants who have contributed have given written informed consent according to declaration of World Medical Association. So all participants completed a standardized neuropsychological test, battery sensitive to cognitive impairment associated with TBI. The cognitive functions interest were indexed through current verbal and non-verbal reasoning ability via the Wechsler abbreviated scale, that is of intelligence similarities and matrix reasoning subtest. Associative learning and memory via the immediate recall score on the people test from the doors and people test. The executive function of set shifting, inhibitory control, cognitive flexibility, and word generation, fluency, recall score, I said a recall score. So now the set shifting, inhibitory control, cognitive flexibility, and word generation, that is by trail making test, alternating switch cost index, time to complete alternating later, and number trails B, time to complete number only trials A. The two indices from the Dahal-Kaplan executive function system, namely the inhibition switching minus baseline score from the color word subtest high score indicating poor performance and the total score on letter fluency, and last the information processing speed via the median reaction time for accurate responses and a simple computerized choice reaction task. Each patient that had standard high resolution and gradient echo, that is T2, imaging to assess focal brain injury and evidence of microbleeds. MRI was performed on Philips 3T HEY scanner, Philips Medical Systems India. Using a body coil, the T1 and T2 weighted images were obtained prior to DTI. For DTI diffusion, weighted volumes with gradients applied in 16 non-collinear directions, which are collected in each of the 4 DTI runs, resulting in a total of 64 directions. The following parameters were used: 73 contiguous slices, slice thickness 2 mm, field of view 224 mm, matrix 128 into 120, voxel size 1.75 into 1.75 into 2 to mm3, B value was 1000, and 4 images with no diffusion weighting, B equals to 0 SMM square. The images were registered to the B equals to 0 image by affine transformations to minimize distortion due to motion and eddy currents, and then brain extracted using brain extraction tool from the FMRIB software library imaging processing toolbox. Fractional anisotropy and mean diffusivity maps were generated using the diffusion toolbox, as well as images for each of eigenvalues for 1, alpha 2 and alpha 3, representing the magnitude of diffusion in 3 principal directions, axial Tx and radial Trad. Diffusivity images were then derived from eigenvalues Ax1 and Drad 2 by 3 by 2. So voxel-wise analysis of fractional anisotropy, mean diffusivity and axial and radial diffusivity data was carried out using TVSS. Image analysis using TVSS involved a number of steps. Number 1, non-linear alignment of all subjects' fractional anisotropy images into common FMRIB 58 fractional anisotropy template space. Number 2, affine transformation of aligned images into standard MNI 152 1 mm space. Averaging of aligned fractional anisotropy images to create a 4D mean fractional anisotrophy image. Thinning of mean fractional anisotrophy image to create a mean fractional anisotrophy skeleton representing the center of all white matter tracts, and in this way removing partial volume confounds. Thresholding of the fractional anisotrophy skeleton at fractional anisotrophy, that is below 0.2, to suppress area of extremely low mean fractional anisotrophy and exclude those with considerable inter-individual variability. Similar steps for processing non-fractional anisotropy images were then carried out to obtain the mean axial and radial diffusivity images. Non-parametric permutation based statistics were employed using randomized with threshold-free cluster enhancement and 5000 permutations. So now this is figure 1. A threshold of P50 the results corrected for multiple comparisons. Age and gender were included as covariates of no interest in all TVSS analysis. In addition, patient with and without microbleed, evidence of diffuse axonal injury were compared against each other, microbleed versus non-microbleed, and against the control. Since severity of injury is also likely to impact upon the extent of white matter disruption, we carried out additional comparisons between patients classified as mild and moderate, severe, that is control. As DTI changes are known to evolve after injury, we also investigated the effects of time since injury on the group difference in white matter structure. So you can see in the figure 1, figure A, Z equals to 33, Z equals to 17 and Z equals to 23. So this represents white matter lesions that is visible on gradient echo imaging. And number B is contusions. So the color bar indicates the number of patients who had lesions at each site. These are the lesions, the color bar which is shown in the figure. Green yellow indicates where lesions are present in 11% of 28 patients with traumatic brain injury, and the pink indicates where the present in 2, that is 7%, and blue, where a lesion was found in 1 patient only. This is the table. So number A, the following exploratory data analysis using box plots, outlier score, interquartile range outside the middle half of sample were excluded variable wise. Patients showed significantly better performance for intellectual ability, but for all significant group differences control outperform patients, not significant at P below 0.05 label, P4 0.05 and P after 0.01. And the final one was P below 0.001. So this is the intellectual ability, that is verbal and non-verbal. Cognitive variable similarities, 39.7, you can see the figures out here. That is control mean positive minus SDA, traumatic brain injury versus control B, which is right T. These are the processing speed, these are memory associated memory, processing speed, naming, reading. This is for executive function, trail making test, B minus, executive function, cognitive flexibility, and generation fluency, data fluency, F plus A plus S. That was minus 2.4 star, and processing speed, choice reaction time, median reaction time. So now the analysis, the relationship among white matter structure and cognitive function was investigated within the framework of a general linear model in the fMRIB software library. The effects of group and cognitive variables were modeled following analysis of relationship between white matter structure and cognitive function across boxes. So overall, correlations across both group, correlations within each group and group interactions were examined. Analysis was carried out using the people test, immediate recall, total score to index, associated learning and memory. The number 2, the trail making test, trail B, trail A, alternating switch cost, the Dahal-Kaplan executive function, system call over elevation, switching minus, a combined baseline of naming and reading speed, and the Dahal-Kaplan executive function system, that is letter fluency total for letters F, A and S, to index the executive function of set shifting, cognitive flexibility and word generation fluency. And the final one was median reaction time for accurate trials on choice reaction, perhaps to index information processing speed, that was shown in table 1. One control, subject and one patient were extreme outliers on either the alternating switch cost or cognitive flexibility analysis, and this was modeled in design using separate regressors. Permutation-based significance testing was carried out as described above. For illustrative purposes, fractional anisotropy and diffusivity values from the peak voxels of significant clusters of interest were then extracted for each participant from their skeletonized image and plotted against the cognitive scores. Magnetic resonance imaging. T1 imaging was normal in 61% of patients and T2 normal in 25%. Definite and possible intraparenchymal microbleed indicative of a diffuse axonal injury were found in 50% of the patients. 11 males, mean age 38.9 plus minus 9.9 years. Average time since injury was 26 months. Non-microbleed group 10 males, mean age 38.9 plus minus 14.5 years. Average time since injury 25 months. The median number of microbleed was identified using the microbleed anatomical rating scale that was ranging from 1 to 19. Microbleeds were mainly found in frontal and temporal white matter. Bilaterally, there was little overlap in the location of white matter damage. Cortical lesions were found in 39% of all patients and were mainly seen in frontal and temporal regions. Again, there was a relatively small amount of lesion overlapping. So we before saw in figure 1, magnetic resonance signal abnormality indicative of superficial cytosis was found in 43% of the patients, mainly overlying bilateral frontal and right temporal cortices. This is possibly to be secondary to chronic hemosiderin deposition as a result of subdural or subacronoid hemorrhage at the time of injury. The patient group outperformed the control group in terms of average current intellectual ability as indexed by Wechsler abbreviated scale of intelligence, similarities and matrix reasoning controlled for age. However, the patient showed a pattern of specific cognitive impairments, characteristics of traumatic brain injury. This controlling for intellectual ability, they showed the results impaired associative learning and memory on the people test, impaired executive functioning as shown by inefficiencies on trail making test, caller word inhibition, switching and letter fluency. And final one was impaired information processing speed on the choice reaction task and all other measures of processing speed apart from word reading. Evaluation of patient with TBI and age match control revealed that the majority of the white matter confirms some evidence of disruption in the TBI group. The between group differences were most clear for fractional anisotropy and mean diffusivity, with less extensive but still marked differences seen for axial diffusivity and much more limited differences seen for radial diffusivity. Lower fractional anisotropy was found in TBI group in interhemispheric fibers, genu body, and splenium of corpus callosum, and intrahemispheric association fibers of uncinate fasciculi, inferior and superior longitudinal fasciculi, inferior fronto-occipital fasciculi, and cingulum bundle. Lower fractional anisotropy was found in projection fibers of corticopontine and corticospinal tracts, as well as in phonesis, the anterior and posterior thalamic projections, the forceps major and minor, the anterior and posterior limbs of internal capsule and anterior corona radiator. We can see in figure 2a. The same contrast showed high mean diffusivity, similar locations as lower fractional anisotropy, but more extensively in left superior longitudinal fasciculus and also in external capsule bilaterally. We can later see in figure 2b, elevated axial diffusivity in traumatic brain damage group that was seen in several tracts, including corpus callosum, bilateral uncinate fasciculi, the right superior and inferior longitudinal fasciculi, the cingulum bundle that was bilaterally underlying the posterior cingulate cortex, the corticospinal tracts, the phonesis, anterior thalamic radiations bilaterally, the forceps major and minor, and the anterior and posterior limbs of internal capsule. Radial diffusivity was higher for patients in corpus callosum, the right superior longitudinal fasciculus, the right posterior medial parietal white matter underlying, the posterior cingulate and precuneus cortices, the phonesis, bilateral anterior thalamic radiations, and forceps minor, but to a limited extent only. There were no white matter regions that confirmed either higher fractional anisotropy or lower mean axial or radial diffusivities in patient group. Next, we examined whether the time since injury stimulated these group differences in white matter structure. Its influence was primarily visible in axial diffusivity and mean diffusivity. Elevated axial diffusivity was correlated with increasing time since injury, or equals to 0.49, P below 0.01, an effect that was present when controlling for patient age or partial 0.45, P greater than 0.05. A similar result was found for mean diffusivity, R equals to 0.55, P greater than 0.01, R partial 0.46, P greater than 0.05. Time since injury was not correlated with either fractional anisotropy or radial diffusivity once patient age had been controlled. So now this was the figure to the disruption and following traumatic brain injury. Axial slices of results of fractional. Number A is fractional anisotropy, that is FA. Number B is MD, mean diffusivity. Number C, that goes to axial diffusivity, DAX, and number D, radial diffusivity. So the TBSS contrast between traumatic brain injury and control groups. So this was the MRI image. The fractional anisotropy, the red one, that was controls for traumatic brain injury. The red ones showing in figure is control. Mean diffusivity, the dark blue shows traumatic brain injury for controls. TAX yellow, traumatic brain injury for controls, and DRAD, the light blue shows DRAD, traumatic brain injury for controls. The contrast were overlaid on standard 152T1, 1 mm brain, and mean fractional anisotropy in green with display thresholds set to range from 0.2 to 0.8. The results were thresholded at P 40.05, corrected for multiple comparisons. So the patients with extensive white matter damage, as anticipated, the evaluation of patients with microbleed and those without non-microbleed revealed evidence of more severe disruption in microbleed group in large parts of white matter. Considerably lower fractional anisotropy, for contrast of microbleed versus non-microbleed patients, was determined in the body and splenium of the corpus callosum, as well as bilaterally within the inferior longitudinal fasciculi, the corticopontine, corticospinal tract, the fornices, and the thalamic radiations. The internal and external capsules and within white matter structures of midbrain. The discussion of superior cerebellar peduncles. There were additionally higher mean diffusivity for patients with microbleed in large part that was corresponding to the location of lower fractional anisotropy, including bilateral inferior longitudinal fasciculi, the corticospinal tracts bilaterally, fornices, bilateral anterior thalamic radiations, the posterior limb of internal capsule and external capsule. In addition, higher mean diffusivity was observed in superior longitudinal fasciculi, the cingulum bundle bilaterally underlying the posterior cingulate and retrosplenial cortices, and the forceps major and minor, but most effective in posterior body and splenium of corpus callosum. The patient with microbleed also confirmed significantly elevated radial diffusivity in several white matter tracts. Those corresponded to the tracts showing either lower fractional anisotropy or higher mean diffusivity or both. Apart from the superior longitudinal fasciculi and the forceps minor on right that showed higher mean diffusivity in absence of elevated radial diffusivity. In axial diffusivity, there have been no group differences among the patient with and without microbleed. Again, there were no white matter regions that showed either elevated fractional anisotropy or lower mean axial or radial diffusivities in microbleed group. So patient without microbleeds and of white matter damage. To assess whether DTI is more sensitive to the presence of white matter damage, then gradient echoimaging we compared patients without microbleed, the non-microbleed group that with controls. Considerably lower fractional anisotropy was found in patients without microbleeds in the body and genu of corpus callosum, both corticopontine tracts and right forceps major. Mean diffusivity was substantially elevated in non-microbleed group in several tracts, including the corpus callosum, the cingulum bundle bilaterally, the corticopontine, corticospinal tract, the fornices, the forceps major and minor, and anterior and posterior limbs of internal capsule, more so on right that will be shown in figure 4b. Axial diffusivity was higher for the patient without microbleed in locations largely similar to those in which mean diffusivity was also elevated, including the corpus callosum, other than the rostrum, the fornices and cingulum bundle bilaterally, but not in internal capsule or forceps major and minor. There were no vast group differences in radial diffusivity. There were also no regions where fractional anisotropy was elevated or mean axial or radial diffusivities lower in non-microbleed group as compared with controls. These results demonstrate the presence of white count abnormalities in patients with no microbleeds on gradient echoimaging. As expected, the same contrast between patient with microbleed and healthy controls showed extensive white matter abnormalities with the patients. This is the figure 3. Patient with microbleed, evidence of diffuse axonal injury that saw more extensive white matter damage. The results, A is fractional anisotropy, B mean diffusivity, and C is radial diffusivity. So TBSS contrast between patient group with and without microbleed, evidence of diffuse axonal injury, fractional anisotropy. The red one is fractional anisotropy, non-microbleed, 4 microbleed, mean diffusivity is dark blue, microbleed, 4 non-microbleed, and TRAD light blue. DRAD is light blue. Microbleed, 4 non-microbleed, The contrast were overlaid on standard 152 Ti1mm brain and mean fractional anisotropy skeleton, that is in green. So the result are thresholded at P40.05, corrected for multiple comparisons. So DRAD was X is to 0 and Y equals to -30 and Z to 0 equals to 50. This is another figure. The patients without microbleed can also evidence of white matter damage. The results: number A is fractional anisotropy, B mean diffusivity, C axial diffusivity. So TBSS contrast between patient without microbleed evidence of diffuse axonal injury, non-microbleed and controls. Fractional anisotropy is red, red and controls for non-microbleed. Mean diffusivity dark blue, non-microbleed for controls, and DX yellow, non-microbleed with 4 controls. The results are same like P40.05. Patients classification that was solved with white matter abnormalities. We also examined the relationship between traumatic brain injury, severity as defined using Mayo classification system, and white matter damage. Although the mild group consisted of only 8 patients, they showed a lower fractional anisotropy compared with control in a wide range of tracts. These included the fornices, the cingulum bundle, bilaterally the corpus callosum, the anterior limb of right internal capsule, and left external capsule. The inferior fronto-occipital fasciculi, the left superior longitudinal fasciculus, forceps major and minor bilaterally. The anterior thalamic radiations was bilaterally and corticospinal threads. The mild patient also showed elevated mean diffusivity in similar but more widespread tracts with additional differences seen in internal and external capsules, bilaterally and superior longitudinal fasciculi. Axial diffusivity was higher for mild patients than control in corpus callosum. The inferior fronto-occipital fasciculi, the posterior cingulum bundles, the left superior longitudinal fasciculus, the posterior limb of internal capsule, the corticospinal tracts, and both anterior thalamic radiations. The mild patients had higher axial diffusivity than the moderate, severe patients in body and genie of corpus callosum. A difference that was still present after controlling for time elapsed since the injury. There were no other difference in any of DTI metrics between mild and severe patients. As expected, there were very widespread differences in fractional anisotropy. It was controlled by 4 patients and mean and axial diffusivities patients with 4 controls between moderate, severe patient and control. These differences were seen within the fornices, the corpus callosum, all major intra-hemispheric association and projection fibers. The internal and external capsules and superior and anterior corona radiator. The radial diffusivity measurements were not different between any of these 3 groups. Associative memory. Across both patient and control, we found evidence that structure of fornices predicted associative memory performance. As expected, fractional anisotropy within the fornix was positively correlated with memory, showing that individuals with more anisotropic white matter within the fornix had better performance. Relationship between fractional anisotropy and associative memory was observed in both patient and normal groups. Using the stringent permutation test, we employed this relationship was of borderline significance when corrected for multiple comparisons across the whole brain. Is P greater than 0.06 in the right fornix, peak voxel x goes to 7, y goes to -5, z goes to 9, and p was greater than 0.07 in the left fornix. The peak voxel goes to -2. These are the measurements. In the peak voxel within the fornix, fractional anisotropy was significantly correlated with our measure of associative learning and memory across both groups. That was R2 and p greater than 0.01, the figure goes to 0.25. The TBSS test for linear relationship between white matter structure and cognitive variables, but this relationship may not be best modeled linearly as suggested. For this reason, we fitted a second order polynomial regression slope which models the data more accurately. R2 was 0.33 and P greater than 0.001. This relationship was specific to the hippocampal formation, as there were no significant reasons outside it where fractional anisotropy was correlated with measure of memory function. So that means the memory function was impaired. The relationship was also present when controlling for intellectual ability. R partial 0.48 greater than 0.001 and then A and COVA with severity as between subjects factor. So no significant interaction between severity and fractional anisotropy. That was measured with peak voxel from the phonics memory relationship. No significant correlations between associative learning and memory and white matter structure were observed for any of these three diffusibilities. More complex relationship between white matter structure and executive function was observed. There was no relationship between our executive function measures and fractional anisotropy, but a significant relationship was observed between set shifting as measured by trail making test, alternating switch cost index, and both mean and residual diffusivity. Increases in mean and radial diffusivities had previously been reported after traumatic brain injury and are thought to be indicated axonal injury. In the whole brain analysis, the patient group showed an expected correlation between elevated mean diffusivity and executive dysfunction. So patient with high mean diffusivity, left superior frontal, white matter showed worse performance. A subsequent analysis within all significant voxels confirmed this relationship. R partial equals to 0.75, P greater than 0.001, that is for controlling intellectual ability. There was no such relationship in healthy control group, in the groups combined or in interaction between the group. A highly significant group interaction was observed between radial diffusivity and alternating switch cost. Whole brain corrected at P greater than 0.01. This was in striking contrast to our result for relationship between fractional anisotropy and associated learning and memory, where a similar effect was seen across the groups. The voxels were the two groups that saw distinct relationship with executive function that was seen particularly in frontal white matter connections, including the cingulum bundle, the body engine of corpus callosum, the right superior longitudinal fasciculus, and right corticospinal tract. The peak effect between superior longitudinal fasciculus and cingulum bundle. There's sensitive correlation between variables in the patient group. It was R2, 0.30, P greater than 0.01, but no significant relationship in control group. Similar result emerged when we examined all voxels showing the significant interaction effect. That was positive relationship observed between the variables in patient group R2. It was 0.17 and P greater than 0.05, but no relationship was found for the control. Therefore, patient with high radial diffusivity in this white matter region had more executive impairment. This relationship in the patient group remained significant after controlling for intellectual ability. R partial, it was 0.53, P greater than 0.01 in peak voxel, and R partial was 0.43, P greater than 0.05 across all significant voxels. An ANCOVA with severity as between subjects factor showed no significant interaction between severity and radial diffusivity in peak voxel or across all significant voxels. So we also analyzed each group separately. In the control group, an unexpected negative relationship was found between executive function and radial diffusivity, in that increasing radial diffusivity was related to better executive function. This relationship was seen within parts of corpus callosum, the superior longitudinal fasciculus, and cingulum bundle. This analysis identified a set of voxels that was only partially overlapping with the results of interaction analysis. There was no significant relationship between executive function and radial diffusivity in the patient group alone in whole brain analysis, but the pattern of correlation was reversed to the control group. So two analyses show that was a complex relationship that exists between executive function and white matter structure. There was voxels in different part of white matter showing different structure, function relationship in healthy and damaged brain, functional anisotropy and axial diffusivity, were not associated with set shifting as indexed by alternative switch cost, that is on trail making test. In addition, other two executive function investigated, excuse me, that is cognitive flexibility and word generation fluency, that did not show a significant relationship with any of the DTI measures. So this is another figure that is TBSS regression analysis of associative learning and memory. People test immediate recall total by fractional anisotropy across the brain traumatic injury and control group. So the figure A are the areas where fractional anisotropy is positively correlated with people test. Recall score across the two groups that are indicated in red color, that is FA by PT, is to all positive. The result is overlaid on a standard 152 Ti 1 mm brain and mean FA skeleton in green. For display purposes, the result is displayed with the multiple comparisons, threshold of p greater than 0.1. So the figure B is a graph showing individual data points in both groups for people test recall score against fractional anisotropy in peak voxel. You can see the graph, the TBI versus COI that grows really high, x equals to 7, y equals to -5, and z equals to 9. FA in peak voxel that goes from lower to higher. A second order polynomial regression slope is shown, in which that provides a more accurate fit than the linear regression identified by whole brain general linear model analysis. CON, the blue dots, that is control. TBI, the red one is traumatic brain injury, that is shown in slope of the graph. Another figure, that's the result of TBSS regression analysis of group interaction between alternating switch cost, trail making test, A and B, radial diffusivity DRAD in the traumatic brain injury and control groups. So the figure A that shows the result of whole brain analysis with significant areas of interaction effect for DRAD, TBI plus SON minus shown in light blue, the light blue color. The results are thresholded at p greater than 0.01, corrected for multiple comparisons and overlaid on standard 152 Ti 1 mm brain and mean fractional anisotropy skeleton, that is in green. Graph illustrates linear regression slope for each group. Individual data points for alternating switch cost against DRAD in peak voxel, x equals to 80, y equals to -38, and z equals to 36 of the interaction effect. DRAD values are expressed as mm square xx 10-3 for convenience of display. CON is control and TBI traumatic brain injury. Alternating switch cost. So the information in the whole brain analysis, information processing speed, that is measured by median reaction time for accurate responses on choice reaction task, that was not found significantly associated with any index of white matter structure. So elevated axial diffusivity after traumatic brain injury and cognitive function. That is demonstrated previously that patients who show relatively large increases in axial diffusivity in the first year following the head injury have a more favorable outcome. So this raises the possibility that elevated axial diffusivity post-traumatic brain injury is a marker of axonal recovery. That is observed that increases in posterior limb of internal capsule, a descending motor pathway with a well-known normal structure in architecture. This prompted us to perform a focused analysis test, that is of axial diffusivity within this part of white matter. We tested for partial correlation between axial diffusivity and 5 cognitive variables described above, controlling for age, time since traumatic brain injury, and current intellectual ability. Processing speed was negatively correlated with axial diffusivity, R partial minus 0.55, P greater than 0.0, such that patient with highest axial diffusivity in posterior limb of internal capsule had the fastest reaction times None of other four cognitive variables showed a significant relationship with the physical. So we have demonstrated the relationship between white matter abnormalities and cognitive function, that is in two domains commonly affected by TBI, memory and executive function. The work builds on previous studies which show that DTI is a sensitive technique for imaging white matter damage in TBI. In general, these studies have used a reason of interest approach. This involves the investigation of relatively small amount of white matter within regions that are defined on basis of priori judgments. Here, for first time, we used tract-based spatial statistics, that is a box-based approach, voxel-based approach to explore the relationship between white matter structure and cognitive function, that is followed by traumatic brain injury in a data-driven manner. This is particularly important as the cognitive deficits commonly observed after traumatic brain injury, such as executive impairment, are likely to depend upon the disruption of distributed brain networks by diffuse axonal injury. Our results show that widespread white matter abnormalities persist following TBI and that the pattern of damage to specific white matter tracts predicts some aspect of profile of cognitive deficits that are already present. Variability in cognitive function in our patient cannot be explained by limited and largely non-overlapping pattern of focal cortical damage. In contrast, across both patient and control, the structure of OLCIAS was related to efficiency of associative learning and memory. Previous work has shown the importance of phonics for memory function. In humans, damage to phonesis produces memory deficits, and in monkey, the phonics has been shown to be critical for rapid learning of new spatial and non-spatial associations. Following traumatic brain injury to predict memory impairment and indefensibility with one hippocampal formation has been shown to predict associative memory function. We extend these observations by showing that structure of phonesis is specifically correlated with efficiency of certain aspects of memory function. So previous region of interest study have not examined the effect of traumatic brain injury on phonics in terms of memory. Using TBSS, we were able to investigate individual white matter tracts that can be confident that our result is specific to the hippocampal formation. Although white matter abnormality was present, we found no other areas that significantly correlated with memory function. The results also suggested that the relationship between phonic structure and memory is not limited to patients with TBI. As we have used a cross-sectional study design, we cannot completely exclude the possibility that there may be pre-morbid differences in phonic structure between two groups. So, however, this seems a highly unlikely explanation for our results, particularly when one considers that the patients show a specific pattern of cognitive impairment typical for TBI. In association with better current intellectual functioning than the control group, instead the results suggested that fractional anisotropy within the cortex is positively correlated with associative memory performance in healthy brain. TBI appears to modulate existing relationship by disrupting white matter structure. An existing continuum with a less efficient structure-function relationship. Mechanical factors may be important, explaining the prevalence of this type of memory impairment after traumatic brain injury, as the phonics is likely to be particularly susceptible to shearing and tearing forces due to its arc-like shape and long fiber tracts. In contrast, the patient of control group and relationship between white matter structure, that was radial diffusivity, and one of our three indices of executive function. Our voxel-wise approach made it possible to explore this complex relationship. Standard DTI analysis involves the placement of regions of interest. This requires a prior knowledge of likely location of interest, which is both difficult and restrictive. As understanding of structure function relationship is limited and white matter damage diffuse. So TBSS approach allows the relationship between variables to be modeled in the framework of general linear model that does not require the placement of specific region of interest. Previously reported correlation between fractional anisotropy that was in small part of anterior corona radiata and executive function following mild traumatic injury. Their analysis focused on two small results that showed white matter cognitive function, relationship, and control. We extend these findings by investigating a more severely affected group and using a different DTI metric to demonstrate that the patient with more executive impairment have more white matter damage in a number of tracts that connect the frontal lobe to more posterior brain regions. This is consistent with the proposal that executive dysfunction following brain injury is partly the result of frontal lobe disconnection. So in contrast, we did not observe a significant relationship between fractional anisotropy and executive functions, although it is possible that the higher general intellectual function in patient might obscure an overall correlation of fractional anisotropy and executive function across the two groups. However, this was the impact on within good patient analysis, the wide differences. So the brain injury suggests the normal structure function relationship. Similar relationship found between frontal connectivity and executive function has been observed in studies of normal aging, wherein older adult reduced integrity in tracts connecting frontal regions. That suggests the different pathologies that can produce similar cognitive impairment damage to these tracts. DTI is extremely sensitive to white matter damage following TBI. Reduction in fractional anisotropy and axial diffusivity emerge in first few hours after the cortical contusion in experimental models of TBI. And these early changes reflect external damage. Tissue injury evolves over time with development of macrophage infiltration, tissue edema, and demyelination, and these pathological changes are reflected in DTI measurement. So in general, low fractional anisotropy persists over time, accompanied by an increased in radial diffusivity that lead to high mean diffusivity, while its changes in axial diffusivity are more dynamic. We also provide direct evidence that DTI can detect white matter damage not seen using the standard magnetic resonance techniques. We stratified our analysis by investigating white matter abnormalities in patients with and without microbleed. The presence of microbleed on gradient echoimaging is a marker of diffuse axonal injury, so that indicates the presence of more severe white matter injury. As expected, the microbleed marker subtle white matter damage and demonstrate that significant white matter abnormality may be present in following traumatic brain injury even when gradient echo-MRI is normal. So we further stratified the patient analysis based on my system. This again demonstrated the sensitivity of DTI in identifying white matter abnormalities in patients classified as mild. So the microbleed analysis, however, the comparison of mild and moderate patient failed to show a difference in fractional anisotropy or mean diffusivity measurements. So the damage was in the criteria of structure, that is not integrate sensitive magnetic resonance measures of damage. 3 of 8 mild patients had microbleed on gradient echoimaging. Therefore, although the mild group was small, it is likely that the known results reflect the inclusion in group of patients with significant diffuse, that is axonal injury, and classifications for traumatic brain injury that fail to include specific measures of white matter damage. So our result also show an overall increase in axial diffusivity. So the mild group of patients, the brain injury produces early reduction in axial diffusivity that gradually normalize over time. On average, we scanned the patient longer after the injury, hence our results suggest that axial diffusivity continues to rise well after the acute phase of traumatic brain injury. The pathological and different studies in human and animal studies were also there. The normalization of axial diffusivity could reflect reorganization within the white matter due to axonal recovery or even regrowth. This region contains descending corticospinal fibers, and higher axial diffusivity in posterior limb of internal capsule was associated with faster processing speed on choice reaction task. So this result therefore provides support for proposal that increased axial diffusivity reflects adaptive axonal recovery, but should be interpreted cautiously as our whole brain analysis did not reveal a significant relationship for any reason. So the patient with TBI, the DTI changes were generally seen in expected dilations. The contrast high radial diffusivity in certain white matter tracts of healthy control was associated with efficient executive function, radial diffusivity, faster nodes, conduction time, and more efficient executive function. That is in degree of axonal myelination. Relationship between DTI, measures of white matter structure and cognitive function, appears not to be this simple. Significant relationship between cognitive function and white matter structure in an unexpected directions have been reported previously. This results emphasize that further work is needed to determine how changes in different aspects of white matter, microstructure in specific tracts are related to cognitive function in uninjured brain and how the DTI metrics are affected by brain injury. Further animal studies and between different DTI measures and pathological effects of TBI. The possible limitation of DTI analysis in presence of partial volume effect, potentially problematic for investigating patients with TBI in chronic phase, as the patient frequently show some degree of brain atrophy. This means that the changes in DTI measures, such as fractional anisotropy, that may reflect partial volumes resulting from contamination of measurements by cerebrospinal fluid. Our approach limits the impact of this problem as TBSS analysis involves skeletonization of white matter and focuses on center of tracts. This removes the white matter at junction with cerebrospinal fluid and gray matter that is prone to partial volume effect. Hence, our approach to investigating group differences is more robust to brain atrophy. So to conclude, we found widespread fractional anisotropy, mean diffusivity, and axial diffusivity differences between patients with traumatic brain injury and healthy control using TBSS. The distribution of white matter abnormality correlated with individual differences in associative learning and memory in one of our three indices of executive function. White matter disruption in phonesis predicted associative memory performance across both groups, whereas a more distinct pattern was observed for relationship between frontal disconnection and executive function in two groups. Our approach reveals the complexity of the relationship between indices of white matter structure and cognition and shows the importance of flexibly analyzing patterns of disruption across the whole brain. Thank you. Thank you, conference team and attendees for being there. So these are the other publications which has been already published. So thank you very much.